Ultrasound is a fantastic tool to help you take care of the patient in your emergency department with undifferentiated shock. I have a 45-year-old patient who's come into the emergency department. He has chest pain and shortness of breath. I want you to be thinking about a patient who comes into your emergency department. He is a 45-year-old gentleman who complains of chest pain and shortness of breath. His vital signs are temperature 37 degrees Celsius, pulse 105, blood pressure 75/50, respiratory rate of 28, and oxygen saturation of 93%. There are multiple protocols that can be followed to elucidate the type of shock your patient has. We're going to talk about some of the views from the Rush ultrasound protocol. This protocol involves 18 views. While that sounds like a lot of information, you are probably already familiar with many of the views. The Rush protocol divides the body into 3 systems: the pump or the heart, the tank or the volume status, and the pipes or the aorta and lower extremity veins. During this protocol, different findings are suggestive of certain types of shock. Determining which type of shock the patient has will allow you to rapidly target therapies. First, we want to start with the heart or the pump. There are 5 questions you should ask. Is there cardiac activity? Is there a pericardial effusion? Is there pericardial tamponade? What is the approximate ejection fraction? And is there evidence of right heart strain? A subcostal or apical 4-chamber view plus a peristernal long axis view can be used to answer these questions. You're probably familiar with the subcostal view from the FAST exam. A low-frequency curvilinear or phased array transducer can be used. The transducer should be placed in the subcostal position with the probe marker pointed toward the patient's right. Let's look at an ultrasound of a normal subcostal view. The apical 4-chamber view is an alternative view. The low-frequency transducer is placed over the apex of the heart with the transducer indicator pointed toward the patient's right. This is a normal apical 4-chamber view. Another view is a peristernal long axis. The peristernal view is obtained by placing the transducer to the left of the sternal border in the 3rd to 4th intercostal space with the transducer indicator pointed toward the patient's right shoulder. This is a normal peristernal long axis view. Now we are going to show different abnormal ultrasound findings. This ultrasound shows pericardial effusion. In this patient, the effusion has progressed to tamponade. Note the collapse of the right ventricle. If the patient does not have enough blood return to the heart, for instance in hemorrhagic shock, the heart will be hyperdynamic. The patient will have a rapid heart rate and a high ejection fraction. A patient with congestive heart failure will have a hypodynamic heart with a low ejection fraction. Finally, if the patient has a large pulmonary embolism, evidence of right heart strain can be present. Normally, the left ventricle is larger than the right. Here we can see the right ventricle is larger than the left. The next step of the exam is to do the 3 traditional intra-abdominal views of the FAST exam. We will now compare normal and pathologic views. Here is a normal view of the right upper quadrant and a video showing free fluid between the liver and the kidney. This is a normal video of the left upper quadrant compared to a view with free fluid around the dome of the spleen. We see a normal transverse suprapubic view and a video with a large amount of free pelvic fluid. You can see the uterus surrounded by fluid. The FAST exam can be extended to look into each hemithorax. Greater detail of these views can be found in the Access Emergency Medicine lung ultrasound video. Briefly, each hemithorax should be imaged for the presence of pulmonary edema, pneumothorax, and pleural effusion. Normal lungs should slide with respirations. The bright white line is the pleura. Note how it slides back and forth. The patient in this video has a pneumothorax. Note the lack of lung sliding. Here, numerous B lines indicate pulmonary edema. This hypoechoic area is a pleural effusion. Now we move to the inferior vena cava in order to evaluate the patient's tank. The vena cava can be imaged to estimate volume status. A low-frequency probe should be used to obtain a longitudinal image of the vena cava. Respiratory variation should be measured 3 centimeters proximal to the atriocaval junction. A normal vena cava will have a collapse of 30 to 70% with respirations. A low-pressure vena cava will be small and collapse more than 70% with respirations. A high-pressure vena cava will have minimal collapse during respirations. Next, we image the patient's aorta and lower extremity deep veins to look at the patient's pipes. From your view of the vena cava, fan your transducer slightly to obtain a long-axis view of the aorta. The aorta is a thicker-walled vessel located to the patient's left of the IVC. After locating the aorta, the transducer should be rotated 90 degrees so that the probe indicator is pointed toward the patient's right side. High, middle, and low images of the aorta should be obtained. Measurement should be made in this transverse view. A normal diameter is less than 2 centimeters. While the risk of rupture increases with size, even small aneurysms can rupture. Finally, we image the deep veins of the lower extremities. Both the femoral and popliteal veins should be viewed. If no clot is present, the walls of the veins should touch with transducer pressure. If clot is present, the walls of the veins will not touch, even when enough pressure to compress the artery is applied. Now I want you to think about our patient. He's a 45-year-old gentleman with chest pain and shortness of breath. He's afebrile, tachycardic, tachypnic, hypotensive, and hypoxic. I'm going to show you different sets of ultrasound videos, and I want you to diagnose the type of shock this patient has. Here we see a hyperdynamic heart, a low-pressure inferior vena cava, and an abdominal aortic aneurysm. So this patient has hypovolemic shock from a ruptured aorta. What if we instead see a patient with a hypodynamic heart, a high-pressure vena cava, and pulmonary edema? This patient has cardiogenic shock, and we will initiate a very different treatment. Ultrasound is a fantastic tool to help you take care of your critically ill patient with undifferentiated shock.